groups and the race, or the COVID-19 severity in the blood groups, various blood groups and race. So let us start our discussion. The first discussion is about the blood groups. I'll tell you the summary of the discussion before we discuss that in detail. The summary of the discussion is, it's a non-peer reviewed study. It is only one study so far. And the authors of the study, they claim that the data that they gathered, that data shows that the blood group A is most at risk for COVID-19 infections and severity of the infection. And blood group O is least at risk of catching the infection, and the severity of the infection is low in these patients, in these persons as well. Good morning, everyone. So this is the first time I am looking at a study that says that catching the infection may be different as well in certain cases. So very, very interesting. It is not peer reviewed. It is not verified. There needs to be more studies done like that. However, that the data that they have presented and the way they have analyzed it, that seems appropriate, but still the study or similar studies need to be done. So let's look at that study. It is very interesting. And let's look at the blood groups and the reason that this may be happening. Welcome, everyone. Let's start. We'll talk about the blood groups and the severity of COVID-19. And this is the first time we'll talk about a topic in which we'll talk about a factor like blood group, which increases the chances of catching the virus as well. So let's look at it. And then we'll talk about race as well. So here, if I can very quickly bring in the studies in front of you as well. So unfortunately, we are at 4.2 million infections and about 290,000 deaths. Okay, so here is the study. The study is here. What they did was authors that they said we took 2,173 patients with COVID-19 confirmed. And then I want to show you their data as well. So give me 1 second. I want to bring the data in front of us. Their data analysis is this, that in Wuhan, the distribution of the blood groups in normal, regular people was 32%, 24%, 9%, and 33% of A, B, and O. However, look at the infections. The A group had 37.75% infections, and their death rate was higher as well. And the other two, B and AB, are not statistically significant. However, O group was statistically significant as well, that they had very less infections and death rate. So look at this, 25.8% was the infection rate, while their percentage in population was 33.84. So let's look at this a little more and see why this was happening. So this is that study. I showed you their analysis as well. Now, very quickly, what are the blood groups? So look, what happens is that our red blood cells, so if I make a red blood cell over here, our red blood cells have glycoproteins attached on their surface. Almost all of our cells have glycoproteins attached on their surface. In case of some people, attached to this glycoprotein is another component or element that we say is a blood group antigen. And again, we did not know this. These things were studied after the blood was given from animals to humans and the humans would die. Then the blood was given from human to human in the early time of the medicine. And then some humans would not die and some humans would die. And that started this discussion and research that what happens in case of in some cases when people die. So that is when this discussion started and exploration started. That is when these antigens were explored. What is the exact mechanism of these antigen? What is their benefit? It is not known. It is known that these antigens presence or absence can cause some diseases, increase risk to diseases or not. For example, today we're talking about the COVID-19, excuse me, and we are saying that blood group O, which is, I'll talk about it, absence or presence of absence of both antigens, somehow is more prone, less prone to COVID-19. So these blood groups can have propensity towards various diseases to be higher or low. But let's look at what the blood groups are. So we have these glycoproteins, red ones, and then attached to them is an antigen. So let's say this is antigen A. What that means is that my immune system will not make antibodies against A. So let's say if I am blood group A, then my red blood cells will show antigen A on them, and my blood or my immune system will not make antibodies against this antigen. Of course, if the immune system made antibodies, then my RBC would be killed. And that is what happens if somebody is blood group A and you give them a blood group which is not compatible, the antibodies would attack the blood and kill those cells. So blood group A does not have antibodies A. However, it has, let's say, antibodies to B, anti-B antibodies. What that means is that if we transfuse this person with blood group B, then the antigens that would come in from B will be attacked by the receiving person's anti-B antibodies, and there will be hemolysis and there would be reaction. So is this clear? In case of B, for example, if this is a blood group B, that means the person has B antigen on their RBC, and that means they cannot have anti-B antibodies. Right? So they have, if somebody is having issue with the sound, it may be on their end as well. Because I think others are okay with the sound. Okay, so continue. If I am blood group B, for example, then I will have anti-A antibodies, but not anti-B antibodies. Is that clear? So think about it now. If we have these blood groups here, this is the blood group A. Look at his expression. He's a little sad because people with blood group A are more at risk of COVID-19 and higher intensity of COVID-19 as well. Blood group A will not have anti-A antibodies. Why do I keep stressing this? Because the mechanism of protection is related to this antibody. So they don't have this antibody. Blood group B have B antigen and they do not have anti-B antibody, but they have anti-A antibody. Blood group AB do not have anti-A or anti-B antibody. And blood group AO, this guy, most happy one, this guy does not have any of the antigens. That means he has anti-A antibody, anti-A and anti-B antibodies. So this is the basic important thing to remember. At this time, from this diagram, if you can just please remember this, that there are anti-A antibodies that are important, and blood group A do not have it. Blood group AB also does not have it. Wherever there is word A, letter A, they don't have anti-A. And then B and O have it. Now let's look at this study for once more. If I go down here, near the end of the study, here they're saying anti-A antibodies specifically inhibited the adhesion of SARS-CoV-2 protein, SARS-CoV-S protein with the ACE2 expressing cells. So remember, we have been talking about this, the ACE2 and the SARS-CoV, although they are giving you example from SARS-CoV, not SARS-CoV-2. But what they're saying is that if we have a cell that have let's say, spike protein from SARS-CoV. I keep saying SARS-CoV, not SARS-CoV-2. So this is an older study. So let's say these are SARS-CoV antibodies, antigens, spike proteins. Then if you connect them with our host cells, we know that they connect with ACE2, correct? This is the same case for SARS-CoV-2 as well. People with blood group O have anti-A, which is also the case with the blood group B. They are postulating that according to this study, blood group O has anti-A, and anti-A somehow hinders that antibody, somehow hinders this binding of the virus with the host cells. That is their basic study. So this study is for SARS-CoV, and they are applying that study back to SARS-CoV-2 as well, and saying that that is one possible mechanism. So that means that if somebody is blood group O, then for them, so here this guy, this RBC, for them they have anti-B, anti-A, and anti-A is going to hinder or obstruct the SARS-CoV-2. Now I'm extrapolating, I'm saying SARS-CoV-2 instead of saying SARS-CoV, to bind with the ACE2 receptors. That should be the same case with the B group as well, because B should also have anti-A, although they did not see this kind of a effect with B. So now let's look at what effect did they see. What they saw was that in Wuhan, where they did the study, 32% of the population was blood group A, 24.9 was B, 9.1 was AB, and 33.84 was blood group O. By the way, blood group O is usually the most prevalent blood group in a population. When they looked at the infections, what they found was that 37% of the patient, 37.75% of the patients hospitalized with COVID-19 were blood group A. So that is a statistically significant number. Similarly, they found that 25.8% were the patients who were blood group O, which is also statistically significant because blood group O has a higher percentage in the population but lower patient percentage. So that is also very important. So these both are significant. So conclusion is O has less infection and less chances of dying, and A has more infections and more chances of dying. So the second statement that I just passed, here is the second part of the study where they looked at the blood groups of the patients who had died, unfortunately, and they saw that 41.26% of the patients were blood group A and 25.24% were blood group O. So these both numbers, once again, are statistically significant. So propensity of blood group A to catch the infection and then to have severe infection is more. Propensity of blood group O to catch the infection and to have a severe infection is less. Now, one of the reasons this study says is the presence of anti-A. Another reason, which is also very important and had been studied in the past for other diseases, is that the blood group, look at this. Another observation is that individuals with blood type O tend to have lower levels of von Willebrand factor. So blood group O have lower von Willebrand factor. So if we can very quickly talk about that, we have been discussing von Willebrand factor for a long time. So remember, if I make a blood vessel here, so this is a blood vessel, if I open it up and we look at the endothelial cells of this blood vessel, we have almost daily discussing that these cells have von Willebrand factor in it. Then underneath the cell in the subendothelial area, we have von Willebrand factor. Then von Willebrand factor is also circulating in the blood. And we talked about it that when it is circulating in the blood, it is connecting with factor 8. It is a stabilizer for factor 8. And we talked about this as well, that when there is a endothelial damage, then that damaged area would cause the von Willebrand factor to become exposed plus collagen to become exposed, so von Willebrand factor then offers a platform for platelets to connect, and that is how the platelet plug would start forming to reduce the bleeding over there. Correct? So now think about it for a second. We are saying that the blood group O has less von Willebrand factor. They sometimes have so less that there are studies that are trying to understand that if they can have von Willebrand disease. So here, this is a study which is trying to figure out that do the blood group O has sufficiently low von Willebrand factor that they develop bleeding disorders, because von Willebrand is a clotting factor. And if somebody has low clotting factor, then they have bleeding tendency. So with this back here, if somebody has less von Willebrand, then the coagulability, the hypercoagulability that SARS-CoV-2 causes, that will be reduced as well. Remember, we talked about this as well, that what happens is kidneys release angiotensin. Angiotensin then goes and becomes angiotensin 1, and that is done by the liver enzyme, correct? Then angiotensin 1 connects with the ACE enzyme in the lungs, primarily ACE, and it becomes angiotensin 2. Angiotensin 2 then connects with ACE2, the enzyme that is also used by SARS-CoV-2. It connects with ACE2 enzyme to become angiotensin 1 to 7. And we have done this many, many times, that this is pro-inflammatory, this is anti-inflammatory. Correct? So this is protective angiotensin 1 to 7. It is protective from inflammation, and this one is pro-inflammation. So now if you think about it, the patients who have persons, I shouldn't call them patients, persons who have lesser anti-A antibody plus, so they have lesser connection of the virus to the cells. So let's say here is corona trying to connect. Number one, they have less binding of the virus to the ACE2, which protects them. Secondly, they make, if you see here, because they have less von Willebrand factor, when the virus has attacked us and our ACE2 is reduced because of the viral attack, and angiotensin 2 is increased, which then causes inflammation, and these folks already have lower levels of von Willebrand factor, that gives them a benefit of not getting rapid and fast coagulation, because they don't have the clotting factor in sufficient quantity. And so they don't form thrombi, they do not form clots with that much frequency and with that much intensity as a person with a greater amount of von Willebrand factor. So these are the two mechanisms by which the blood group O enjoys a better protection than blood group A. Now, why does the blood group A has a higher or a greater risk? The reason for that is that, one, they do not have anti-A, so they do not have that protective mechanism from anti-A of hindering the virus from binding to the ACE2. Secondly, they have more von Willebrand factor, which means they would clot more often compared to the patients who have less von Willebrand factor. So that is about the blood groups. Does this make sense? Is this clear? Two basic ideas, and I hope that these absolutely very interesting. So V is pronounced as F, so it is von Willebrand. Very interesting. And von Willebrand or von Willebrand, as I'm saying, he was a Finnish scientist. Yesterday I said these are two scientist names, so that is Weibel Plade bodies or Plade bodies. These were two scientists. Okay, very good. So if we are comfortable with this part, let's now move towards why African Americans, why Black community in the US is getting more sick and is dying more often from this COVID-19 compared to others. So let's go there. So here, race. And I want to show you a couple of articles as well before we talk about it. It's a very sad thing that this happens, but I watched a video where the presenter said that the reason for this is that Black community has a greater amount of one Willebrand factor, and that is why they are at a greater risk. So that is one of the reasons, but that is not the only reason. There are factors that can be controlled. There are factors that can be worked with. For example, hypertension, diabetes, obesity, salt intake, asthma, so vitamin D deficiency. So there are, von Willebrand is not the only factor for African American community which makes them more prone towards the disease intensity. It is many factors, and I want to talk about all of those factors because a majority of them are under our control or can be controlled. I actually was talking with a person today. She called me from New York, and she said that she needed my help, and anybody else who can help, that would be great as well. She said that the prisoners, they are brought into a reception facility for a week or 2 weeks where they are received and processed, and then they are sent off to the prison where they would live. And in that reception facility, they do not offer them any vitamin supplements or any other such supplements that are crucial at this time at least. And so they are at a higher risk. And she had called me and said that, would you help me figure out how can we ask the administration of those processing reception facilities to at least provide more vitamin D, vitamin C, quercetin, and those things to the prisoners so that they are less at risk. So I said, of course I would. And if anybody else can work with that, work with us as well, that will be great. But let's look at the short of this message that I just gave is for the African American community, it's not just the von Willebrand factor. They can't control it. There are other factors. So I'm going to go through those factors today. So here, first, this is the article here, and I'm sorry, there are cats outside. So number one, the latest available COVID-19 mortality rate for Black Americans is 2.2 times higher than Latinos, 2.3 times higher than the Asians, and 2.6 times higher than the rate for whites. So this is a sad thing, but this is the data. And for each 100,000 people, I have this here. So for each 100,000 population group, out of 100,000, let's say Black folks, 42.8 die. 100,000 Latinos, 19.1, 100,000 Asians, 18.4, 100,000 whites, 16.6. So the African American community is dying with 2.6 times more death rate compared to whites. What does that mean? If in the New York, everybody died, every race died with the same rate as whites, then there will be 10,500 Black community members who would be saved, who would not die. So there are 10,500 disproportionate deaths because of the race. They also did one more study here, and I'll show you this. In Cook County, Chicago, in Cook County, 23% people are Black. However, 58% of the COVID-19 deaths are amongst the Black folks. Similarly, in Chicago, which is, I think, part of the Cook County, 29% of the residents are Blacks, but 70% of COVID-19 deaths are Blacks. So that is a huge, huge implication over here. And I'm going to go through some factors that I can figure out and discuss. I'm sure there are tons of more factors. And so please, if you know those factors, please put them there. So after this, I want to show you this as well. That look at this one. First, in the black population, von Willebrand factor is in higher percentage. So von Willebrand is more. So I'm going to come here for what are the factors. Some people actually tried to uh, minimize this data point by saying that this is just because the hotspots developed in those areas, and because of that it's just increased in that area. So hotspot is not the only factor. Socioeconomic factor is another. The poverty in black community is more. And so that means the nutritional balance, that means the health insurance, that means acquisition of drugs, access to medical facilities. There are many, many factors. That means cleanliness, hygiene, uh, uh, less damp environment, clean environment, temperature controlled environments, and so on. So there are socioeconomic factors as well. So in addition to them, I wanted to talk about medical factors, which are more than just von Willebrand. So one factor is von Willebrand. Black community has more von Willebrand compared to other communities. So that puts them at a higher risk of hypercoagulability. And because I have discussed that just now, I don't want to go into that detail once again. So acoustic theory, that's a very good point, that how about asymptomatic illnesses by race? So I think we cannot figure that out until we start doing testing and start seeing that what percentage of the population is already become sick with COVID-19 asymptomatically and then has recovered. So I know that over here in Santa Clara County, they did this and said about 3.5 to 4.5% of the people were recovered. What I do not know is that if they did the race analysis as well. So very good point though. So number one, von Willebrand factor is high. Number two, please check this one out. Vitamin D levels are usually low. I have a study here that describes vitamin D insufficiency is more prevalent among African Americans than other Americans, and in North America, listen to this, most young healthy blacks do not achieve optimal vitamin D concentration at any time of the year. Meaning out there is sunlight or not, they are exposed to sunlight or not, they do not develop enough vitamin D levels at any time. And the reason for that is the pigmentation in the skin. Melanin in the skin hinders the sunlight from going and converting 7-dihydrocholesterol to vitamin D, pre-vitamin D. So vitamin D deficiency because of the skin pigmentation is very important that they have it. Now, we have discussed this many, many times. I would just very quickly explain it here. Vitamin D, I did that yesterday too. Number one, it is necessary to make cathelicidins, correct? Cathelicidins, if I can type, I can write the spelling correctly. You know that cathelicidins are necessary for chemotaxis. That is the immune system working. They are necessary for phagocyte activity. Again, immune system activity. They are necessary for vascular permeability. Again, immune system function. Then we know that vitamin D is necessary for beta defensins, which are important to punch holes in the virus and try to kill the virus by damaging its membrane. And again, vitamin D is necessary for that. And then nuclear factor K beta is also important and needs vitamin D. And nuclear factor K beta then helps beta defensins to do their function. And that all is vitamin D dependent. So innate immune systems function needs correct levels of vitamin D inside the immune system cells. And if there is not much vitamin D available, then there is another issue of inflammatory immune system failure in Black Americans. So again, I'll continue. You'll probably start hating me for doing this. It's not just the one Willebrand factor. We can control vitamin D levels. We can start providing supplements of vitamin D. We can start educating. We can start sensitizing people to say, hey, take more vitamin D, take more vitamin C, take zinc, take quercetin, eat an apple, do something that helps with this. Then African American community has higher prevalence of hypertension. Actually, in the US, the population with the greatest prevalence of hypertension is African American, 39.1% versus 28.5% in the whites. And not only this, here is the double whammy, here is the further damaging thing. The control of the blood pressure is the least in the African American community. So the prevalence of the hypertension is more there and the control of hypertension is less there. That means there are more people at risk of cardiovascular diseases, coronary artery diseases, and cardiac hypertrophies, which means that coronavirus would succeed more often in these patients to damage them than the non-Black community. So again, hypertension is something that can be controlled. Cardiac issues can be something that can be managed. Salt intake can be reduced. One can go out in sun. One can take vitamin D supplements. So there are things that can be done. Then we also know this, that, and please remember hypertension, I'll explain this as well. Hypertension is also more because obesity is more in the Black community as well. And obesity itself then causes hypertension as well. And so hypertension is for a genetic factor because Black community responds greater to salt, sodium, so their vasoconstriction occurs more than others. And then obesity also leads to hypertension. Then we also know, I have done this discussion before, Black community has greater prevalence of diabetes as well. And we talked about it in another complete hour lecture, that diabetes itself upregulates ACE2 enzymes. Diabetes causes the lack of immune cell responses, and so immune system becomes deficient. And just to give you a simple, very simple logic here, look, what happens in diabetes is this. So let's say this is a blood vessel and this is tissue. Inside the tissue, this is a cell. This cell wants glucose to do its function. Maybe this is an immune cell. Maybe it is a neutrophil or macrophage or some immune cell which wants to do its function. For its function, it needs glucose. In diabetes, what happens is there is glucose. Let's say the patient is eating carbohydrates or body is making carbohydrates. So there is glucose. I'm going to make glucose like a candy here. There is glucose. There is candy. That glucose is present in the tissue as well. And this is why we say that diabetes is a disease which is poverty in abundance, amidst abundance. There is glucose everywhere in the tissue. But insulin resistance is present, so glucose cannot go into the cell, which actually needs it to make energy and to perform its functions. So glucose is there. It just cannot go into the cell in the right amount. And so the cell cannot perform its function. So cells are poor, energy is sitting outside, money is sitting outside on the roads, but the cells cannot pick it up and use it. And so they are poor. And that means all kinds of cell cannot function properly, including the immune system cells. So immune system cells are not working properly because there is a higher prevalence of diabetes, unfortunately, as well. And once again, the control of diabetes is less. Control of diabetes is less. Control of hypertension is less. Amount of vitamin D supplements are less. Nourishment is less. All these things are controllable. If not for a longer period of time, if government can send stimulus checks to everyone, why not to the communities that are at higher risk? Support them first. Sorry, I'm very passionate about this situation. I've always been. Okay, next is obesity. Black community has a higher prevalence of obesity as well. And now, why is obesity so important to discuss at the time of COVID-19. Acoustic theory says even Dr. Bean's cat realizes my note has been stuck on the screen. Sorry, I'm going to take it off. Sorry about that. So, obesity. Sorry, acoustic theory, I did not even look there. So, Crucible, the cat, this is not my cat. So, what happens is because we have cats inside, then there are stray cats who come in and sit down in the window and try to talk with these cats. And sometimes they make these angry noises as well. Okay, so obesity. What happens is in obesity, there is a hormone or a chemical substance. It is called adiponectin, chemical substance released by fat cell. One of the adiponectin type is adiponectin. The fat cells, if I make a cell over here, fat cells, so let's say this is fat and then this is the nucleus. So fat cells release adiponekins, and one of them is adiponectin. Adiponectin is very protective of our body. Very protective. It reduces inflammation, or it suppresses inflammation. It suppresses atherosclerosis. It suppresses cardiac diseases. It suppresses metabolic disorders. There is a bunch of things that it protects us against. However, when somebody has more fat cells than necessary, or I shouldn't say necessary, somebody is obese and they have a lots of fat cells. In the presence of lots of fat cells, what happens is adiponectin function becomes dysregulated, and the amount of adiponectin reduces. So you would think that there are more fat cells, so they would release more adiponectin, but it seems like that adiponectin has a autocrine feedback mechanism where when the fat cells are more and they're making more adiponectin in turn tells them not to produce it in greater quantities. The result is that they all become silent and the adiponectin production reduces. Now, when the adiponectin production reduces, and I want to show you a couple of studies as well. So this is the this is the adiponectin role in obesity. So obesity is a major cause for hypertension and diabetes and others. And adiponectin expression and serum levels are decreased in obese patients and other animals as well. Obese patients and animals. So this is another unfortunate situation, that obesity itself will then not only cause hypertension and not only cause diabetes, but the fat cell dysregulation or malfunction will cause less adiponectin, which in turn will cause, look at this, increase angiotensin level. Adiponectin's function is to reduce angiotensin release. So there is increased angiotensin level, which will then mean that more angiotensin 2, more hypertension, more angiotensin 2, that would mean more pro-inflammatory behavior. Then it causes vascular atherosclerosis, which in turn damages the blood vessels, and that in turn damages the heart. So obesity itself is a grave outcome, or causes a grave outcome by triggering issues with many other problems. And finally, I want to talk more about diabetes as well. Again, why am I talking about these things? Because these can be controlled. We know that diabetics have a higher upregulated expression of ACE2. And ACE2 can make them prone to catching and having a severe attack. So one, and I did this discussion in the other video. So that is why I'm just writing it down here instead of going in the mechanisms, because I've done 1 hour long mechanism descriptions. So number one, ACE2 is upregulated. So that is an issue. Number two, diabetes causes vascular damage that causes atherosclerosis, which causes hypertension, which causes cardiac issues. So coronavirus would love to attack someone and someone's heart which is already weak. So again, African American community has diabetes at younger ages. They have hypertension at younger ages. Diabetes would reduce the functionality of the neutrophils because we don't have enough energy for the neutrophils to work. That would cause infections. Diabetes causes endothelial dysfunction. That endothelial dysfunction leads to hypercoagulability when the coronavirus is present. Diabetes leads to acidosis. Why? Because we do not have the right amounts of carbohydrates, so cells start making energy in other ways like ketones and so on. So the ketone bodies are acids, and what would they do? That acidosis would reduce the immune function. Then diabetic patients have dicarbonyl production, which, look at this, which reduces beta defensin production. And beta defensin, we just talked about it here. Beta defensins are necessary to be able to punch holes in the virus and other pathogens to kill them. So we cannot have good amount of beta defensins. Then the energy for the cell in general is less. So that is the discussion, that it's not just the von Willebrand factor as one of the factors that makes Black Americans or people with dark skin more prone to the infection and the severity of infection, but there are other factors. Vitamin D levels can be controlled. Please distribute vitamin Ds like a gift to others. Diabetes can be controlled. Hypertension can be controlled. Salt intake can be reduced. Health can be observed. One can stay healthy and do exercises. Hypertension, cardiovascular issues, medicines should be taken. And these are the reasons why African American community is at a greater risk, and not at a greater risk, excuse me, they are dying at a greater number as well. So this is the discussion. Thank you very much for joining today. We will continue our talks tomorrow. Please tell me, what would you like to discuss tomorrow? Very good, and thank you. Khalid, diabetic have good control via keto diet, supplementing vitamin A and other recommendations, doctor. So if diabetics have a good control through the ketone diet, plus if necessary insulin or other diabetes drugs, metformin, then yes, take vitamin A, C, D, zinc, please, and add quercetin to it. You are very welcome. I'm quite passionate about this situation with the African American community. I always become a little sad about this, so please don't mind me. Vitamin D3. So vitamin D3 is the supplements, if you can take them, yes. Because look, African American community, even everyone with the dark skin has a difficulty making new vitamin D from sunlight. So they should take supplements. Okay, so tomorrow we should talk about G6PD. We can. So that is a hemolysis disorder, blood disorder, which in case of COVID-19 can become aggravated. Okay, very good. So yeah, so table salt should be reduced. Cardiac issues, diabetic issues, asthma, hypertension, vitamin D levels, vitamin C levels, quercetin, these things should be very well managed. These things can be managed. We cannot do anything about von Willebrand factor, we can have plasma transfusions or the factor infusions, but at least these things can be managed at home. You're very, very welcome. All right, guys. So thank you very much for joining. Please share this. Please like. Please subscribe. And we will continue talking tomorrow. Tomorrow we'll talk about G6PD and the COVID-19. Bye-bye for now.